Go ahead. Okay, members, we're now open to public session. Can I remind members of the protocols surrounding electronic equipment? Item number 1 then is apologies. I have an apology at present from Gary Middleton and Trevor Clark. Any other apologies? Nope. Okay, we'll move on to item number 2, which is chairperson's business. I have no chairperson's business to update at this meeting. Item number 3, draft minutes of the meeting of the 8th of December. Can I refer members to item 3.1 of their meeting pack? Are members content with the minutes?
Great.
Yep. Great, thank you. Item number 4 is matters arising. Further to item 4.2 in the minutes, I advise members that given the items scheduled or rescheduled for the new year, we have asked for the mental health breakfast meeting, which should be held on the 19th of January, to be deferred until the 9th of February. Are members in agreement with that? Yep. Thank you. Item number 5 is correspondence. We're not going to continue with the correspondence. Can I ask permission that we bring all this back to our next meeting? Agreed. Thank you. We'll then move on to item number 6, which is a departmental briefing on the GP crisis. Can I advise members that departmental officials are here today to brief the committee on its response to the crisis in general practice. Can I refer members to relevant papers in tabs 6.1 to 6.7, including recent correspondence from individual GPs, as well as papers from our October evidence sessions with the BMA and the Royal College of GPs. So can I then ask to come forward then Mark Lee, who is Director of Primary Care, the Department of Health, Chris Matthews, Head of Primary Care Medical Services, Department of Health, and Margaret O'Brien of the HSC Board. Where are they? There they are. Okay, you're very welcome today. I just remind members that we have a 45-minute window here before we're back in session. Can I also remind our witnesses of that also, so if you can keep your answers succinct, albeit we do want to hear a full explanation, but try not to, and we'll also try not to repeat things over and over again. So if I can hand over to yourselves.
Thank you, Chair. I thought I'd say a few words of introduction just in terms of Portadown specifically, which I know the committee is concerned about, and then about the broader work to deal with the challenges that GP-led care services are facing across Northern Ireland. So the position with the Banview practice in Portadown does remain fluid, and the Health and Social Care Board is continuing to work with the GPs there to address that particular problem. The practice has approximately 5,200 patients, and until recently there were 2 partners and 2 salaried GPs working there. I think all of them working part-time. One of the partners resigned a few months ago, and both salaried GPs are on maternity leave, one of whom has now resigned. Work has been ongoing to find a new contractor, so there's been contact with neighbouring surgeries to see if there would be interest there in taking on the contract from Banview, as well as the extensive advertisement of the contract. No applications were received by the closing date of the 2nd of December, but the board is continuing to work to find someone who might be willing to take on that practice. So the board has made other practices aware that additional support would be available should they seek to take over that practice, and they have, for instance, held an information evening with practices from the same health centre on the 30th of November, as well as obviously meeting staff from the Banview practice itself on the 1st of December. There have been a number of positive meetings with us, so despite the fact there are no applications received by the closing date of the 2nd of December, there have been a number of positive meetings with a GP who is interested in taking on the Banview practice. Those discussions have been continuing, and indeed we're continuing this morning with that GP who may be interested in taking on that contract. Worth also noting that a temporary list closure has been approved for all practices within the practice boundary of Banview practice, although that only applies to patients who are already registered with a practice there, and that's just about stabilising all the practices in that area, and particularly Banview, so it remains a going concern. Ultimately, if the engagement with GP who may be interested in taking it on is unsuccessful, and there are no other options for someone to take on the contract, the board will look at a dispersal of those patients to surrounding practices to practices near to where they are, and extra support would be provided as part of that to recognise the additional administrative burdens that creates. Worth also perhaps noting the provision of medical cover. So the board has been providing funding for locum support while the practice faces its current challenges. They've also sourced an advanced nurse practitioner who's currently working in the practice, and they've set up GP telephone triage provided by Dalriada Urgent Care Services. So urgent appointments are available through locum GPs and the advanced nurse practitioner working there, and some routine appointments are also available. Though clearly that situation is not ideal, so we would like to move back to a full service as soon as we can. More generally, we recognise the challenges that are facing general practice in Northern Ireland. We've been working with the BMA and the RCGP to look at both the scale of the challenge they face and the 76% rise in demand for GP appointments in the 10 years from 2004 to 2014, and look at what we can do to address that challenge. The Minister has obviously been clear about the importance of primary care, and we have had a process of a GP-led care review setting out a framework and recommendations for actions. The Minister has taken a number of actions already, some of which are covered in that GP-led care review. For instance, announcing the move to 111 training places from a previous baseline of 65 places, and that will happen over 3 years rather than the 4 recommended in the workforce report. Money is also being redirected in undergraduate funding to increase the exposure of undergraduates to general practice. We've revised the GP returner scheme for those returnees to general practice to make it easier for people to return to general practice, put in place a new GP retainer scheme, which has ensured that 25 GPs who might otherwise have been lost to general practice are retained and helped to develop. And we are looking to build the multidisciplinary team that the Minister mentioned as part of her Health and Wellbeing 2026 document. We said we'll roll that out over the next 5 years, but clearly there are immediate actions we've taken, the most obvious of which is the rollout of the practice-based pharmacist scheme. I think there are 54 pharmacists already in place. We're expecting the second wave to begin taking up post in January, and by 2021 there will be just under 300 pharmacists, representing an investment of 14 million per annum working in general practice. We're also working to have named health visitors and district nurses and social workers in place for general practice, and we're trialling new roles which could be part of that general practice team. So for instance, 5 advanced nurse practitioners will begin their training in general practice next year, as will a cohort of physician associates. GP federations also provide us with a significant opportunity to look at the way we work in primary care and to change the model somewhat, to work at scale with GPs and to put in place that new skills mix. And it's also important we use technology to disrupt the way the service is currently delivered and improve it. So the committee have heard about the Ask My GP system. I think we're taking evidence previously. There's also been a recent launch of the online appointment and repeat prescription booking services by the Health Minister, and we could point to other things such as the use of Project Echo, which allows secondary care physicians to support GPs in the management of more complex cases in primary care, and we continue to develop the electronic care record, which provides a way of general practice communicating with secondary care and making referrals there. Conscious of time, Chair, there's obviously other things I could say, but I should also mention that we've continued to invest in the contract over the last couple of years. So over 7 million was put into the contract for 2016-17, and that built on just over 5 million that was made available in 2015-16. So in summary, we recognise the challenges. We've worked with BMA, RCGP and others to assess those challenges, identify some of the key actions that need to be taken. There are some key measures we have already taken, the practice-based pharmacists, 111 training places, but we recognise that there is more that we do need to do.
Thank you. Mark, either do you want to add anything, or can we go straight ahead into questions? Okay, thanks, Mark. The reason we brought you back here today is definitely it's the overall GP crisis that is emerging, because we know every single one of us around this table, it could be any one of our local practices next. But if we first of all deal with the Portadown before I deal with the GP crisis in general, you described the situation as fluid. I know from getting an update from that practice today that they are surviving on locum cover this week, albeit I think they're in great difficulties when it comes to Friday. I also know from the surrounding practices as well, the pressures they're under. You've stated there about that could well happen where patients are dispersed. Can you tell me, will a risk assessment be done on those surrounding practices to see whether they can cope with that influx of patients, how those GPs are going to manage that, because to me it sounds completely unmanageable. And also about the that practice in Portadown, you've told us about the model, about the allied health professional model and social workers and all of the rest of them coming in, which we agree with, I believe is the way forward and is a fantastic model. How quickly will this be done? Because to me it seems like if Portadown had that full multidisciplinary team there, and I know some people have been put in place, things would be a lot easier for them, because we heard from the BMA and from the Royal College, and they have told us on several occasions and told us through correspondence that a massive percentage of their work, people do not need to see the GP. And it's the same with the Ask My GP system, another great system which I think should be put in place straight away, but that cannot work without a full complement of GPs either. So it's just how you propose these things are going to work if we don't have that complement of GPs, and is there a risk assessment done on those other surgeries?
Okay, so taking that first point around the dispersal and the risks there, so the Health and Social Care Board would work very closely with the surrounding practices in terms of any dispersal. They would look very carefully at the number of additional patients each practice was being asked to take on, and they would work with them to provide short-term additional support in terms of the administration and the like, and talk to them about the longer-term needs they would have in terms of potentially taking on some more staff to deal with that. Is there anything additional you want to say on that, Margaret, in terms of the process you're working on?
Thank you. Health Committee is the first time I've been here, so thank you for inviting me along. Just to reiterate, I'm a practicing GP, so I'm head of General Medical Services at the board, so the professional lead, and I fully understand the pressures working on the ground in relation to what general practice is under at this point in time, and we are there very much so to support our practices in trying to manage that challenge at this point in time. In relation to the dispersal, yes, it is a planned process that we go through. What we do is we map all of the patients, then we meet with each of the practices in relation to the potential number of patients that they would have to register. And it's important to point out, whilst acknowledging the demand that our GPs are under, we also have to ensure, and it's a requirement on the board and the department, to ensure that each member of our public, so all of our public, have access to general medical services. So we will work with our GP practices. We will provide additional resource, whilst all of us would love to be able to provide extra GPs, and that is a work in progress with regards to increasing the training numbers, which the Minister has agreed to. We won't have those immediately, so we are looking to skill mix. We have availed of advanced nurse practitioners and an independent prescriber. We have an independent prescribing pharmacist starting practice in January. So it is about making best use of all of the skills that we can, our professional areas, bring into the practice. So to say, whilst we would love to be able to put in additional GPs, we have to use all of our professional groupings. That said, I mean, if I refer to other areas in relation to single-handed practitioners who have resigned, and we have retirements, and you will all again be fully aware of that, and I can go into more detail across the region in relation to that, but they are able, the practices are amalgamating, and as such that gives the younger GPs the incentive to join the practice because they feel more assured, they've got that mentorship from the more senior GPs, they're working in a bigger grouping of professional input, so it does give them that assurance, and they're more willing to work in a practice that has more contractors as part of it, both either as they assign contractors or as salaried GPs. So it's about changing the model that we currently have in primary care, because unfortunately the era of single-handed practitioners just isn't feasible or sustainable going forward.
I understand that, and I don't think there's anyone in this room that would expect that there is an influx of GPs who are going to join Portadown practice, because we don't have them, and we all know that. We're not naive enough to believe that that is going to be the case. I think it's how the situation is managed is something that we need to deal with first and foremost. And I know the BMA have called upon extra funding and various things that they require in order to sustain all of our other GP practices, and I suppose that's what the crux of it is. We know that there's not going to be that massive GP cover in Portadown, but there needs to be something put in, and something needs to be put in as a matter of urgency. Whether it's, you talk about the skill mix, I know there are things being done, it's just for the time frame on that as well.
Absolutely.
You know, we need some reassurance, and those patients need some reassurance.
They do indeed.
That whenever they phone up to have to see their GP, that they can get to see someone. And also for those surrounding GP surgeries, I mean, the amount of sickness levels among GPs and various other things, and stress levels, this is going to impact greatly. I think there's a much wider picture here.
Yeah.
So we want some guarantees, I suppose. The stuff is going to happen pretty quickly to try and alleviate that pressure.
So in terms of some timings for you, Chair, and it's worth just mentioning, I mean, we recognise the stress and the pressure that can occur in general practice, and all GPs can have access to the occupational health scheme that we have in place. Interesting they just brought that in England as something they recognise they need to do. The timings for having named district nurses, health visitors and social workers would be by March 2017. The second phase of the practice-based pharmacist scheme rolls out, has been recruited, and we would expect people to actually start in post from January.
That's right.
So we would expect that practice to have access through that scheme to a practice-based pharmacist from January time. There are some. There's also some funding available through the contract this year for a number of GP federations to look at skills mix. There was just under 2 million made available for them to bring forward some propositions to Margaret to look at how they would put in place a kind of skills mix group that would work across the federation to deal with those patients who need some more intensive support. We're making a lot of use of GP surgery, so we would look at those who could benefit from a kind of more centralised team working with them across the federation. So those proposals are coming in. And then there'll be a piece of work which, and I mentioned obviously we're trialling advanced nurse practitioners and physician associates in terms of training them in general practice. We'll review that and look at the role that we think that advanced nurse practitioners can play more generally, and that physician associates can play, if any, and see whether we should be trying to find some funding to roll out their role more generally. And then I will be leading a broader piece of work which says, well, what should this multidisciplinary team look like? We've got some of the key elements there: the district nurse, the health visitor, the social worker, the practice-based pharmacist. How can we use some of the allied health professions, for instance, or what other people should we be drawing into this team, and how should we draw them into this team? So we'll seek to broaden that team as we go forward over the next 5 years.
Okay, you've mentioned there about extra money that was available at the minute. Was that contracts, did you mention?
That was, so there's this 7 million that I said was invested as part
Is that going to be then, are you going to see that that is targeted to the most need? And I'm sure all of them are in need.
Indeed.
But there will be I'm sure there is a table of which is in.
Yes.
Just a quick yes or no, or a short answer.
Yes, was the case, but at the time, in relation to the contract agreement, obviously it was last April, and at that stage it was agreed with BMA and the department in relation to which 5 federations that funding would go out in the first instance through. In the southern area at that time, obviously, if you reflect back to the issues we had in Crossmaglen, so Newry and Mourne were identified as an area of need at that time. Since then, obviously, Portadown has, as almost in as much need, if not more, at this point. But the Federation Chair, Dr. Arnie McDowell in that federation. I'm waiting on proposals back from that particular federation, but they are actually going to cover the 3 federations in the southern area. So they're not just looking at their own, they're working in tandem across the southern area. And their proposals are in relation to working in a more collective manner around providing GP cover. And obviously those resources will be greatly advantageous to that in regards to targeting those GPs in the practices that need the additional support. So it's good that we are getting the federations working more closely together, and indeed, working more efficiently and effectively. But the funding, as I say, was targeted in the first instance in the Newry and Mourne, but they're going to cover those 3 federations.
Okay, thank you. I have Joanne and then I have Paula.
Thank you, Chair. To focus on Portadown to begin with, that's why I did suggest a committee recall, because it is fairly urgent. I agree with the Chair, fluid. I think I can think of a stronger term to describe it, Mark, rather than fluid. The Minister, in a recent response to me, confirmed the significant pressures at Banview patients had been experienced. These are some of the most socially deprived areas of Portadown, these patients, so it is pretty drastic. I'm concerned, Mark, in your introduction you spoke of no applicants received 2nd December. You're in positive meeting with a GP. That says that there's one GP. You're positive meeting with one GP, because if you read in correspondence today, we have received a letter from a GP, I think it's Dr. Heenan, and with 5,200 patients in Banview practice, she has put a very frank and a very detailed letter to us confirming that she was left with all patients by herself and left working tears. So one GP is not enough to fix this problem. That's certainly not a way to treat professionals. It's quite appalling, actually. So with over 5,000 patients, we would need roughly 2.5 GPs or full-time equivalent GPs. So is that being recognised? Because it did alarm me when you said you were positive meeting with that GP.
Okay, so we're saying obviously GPs are independent contractors, so it's for them to kind of recruit and organise their staff as they want, although we seek to influence that through contract negotiations.
No, but you sort of said as if that would, in fact, that would nearly solve the problem, a GP. Well, no, it wouldn't solve the problem.
So that GP would take on the contract and would then, in the same way the current contract holders, there are 2 principal GPs that have been running it who hold the contract, and they employed 2 other GPs, and then obviously there's probably a practice manager and reception staff, etc. So there is a GP who's interested in taking on the contract. He would then obviously seek to employ other GPs or a combination of GPs, nurses, advanced nurse practitioners, pharmacists, etc., as he would see best fit to meet the needs of that area. I mean, I think you're right, obviously, trying to operate with kind of 2 GPs and 5,200 patients is
that's where we are, where we are.
Indeed.
Challenging wouldn't come close. Obviously, if patients can't get an appointment at a practice, they will naturally migrate to other practices, almost patient dispersal rather than managed dispersal. So do you recognise the risk and the increased pressure then that would bring to neighbouring practices, potentially putting them at risk? What can you do to stop this?
Well, I think the key thing there is to whoever takes on the contract, hopefully this individual we're in conversations with, to support them to get the practice running the way it should. So be very clear, this is a contract with this person to run that practice. GPs are independent contractors, so the onus is on them to run their business effectively, but the board does a lot of work
but if
with
people
GPs
can't get appointments, then naturally have to go somewhere else if you don't get this post filled. And if you can't get an appointment, you will register. That's patient dispersal rather than, you spoke of options dispersal surrounding practice, and you spoke of extra support.
So there is a temporary list closure on the surrounding practices there, so actually patients can't move from Banview to one of the neighbouring practices for the minute. We wouldn't see that as a long-term thing, but to ensure that
Have to go somewhere.
Yes, indeed. Well, for the minute, we would hope to get a contractor in place and get Banview running effectively with the staff in place to deal with the 5,200 people that are on their list. And we would, the Health and Social Care Board would work with that contractor as they come in to help them get up and running, to understand the best way to set up that practice, set up their needs, and to help them get going. But ultimately, it is about those contractors having the responsibility for running their practice effectively.
Do you plan to involve, or are you leaving it to the one contractor, the one GP that's going to potentially take over? Do you plan to involve all practice in the process? Because there's around 45,000 patients, so everything is interlinked here. So the last thing we need is, you know, a process of dispersal. Patients have to go somewhere. It heaps pressure on other practices. What do you plan to do
So
to intervene with this?
we will use the list closure powers, or say we, again, the Health and Social Care Board will use the powers that it has to close lists to stop patients joining
Where do they go?
practices. Well, they would stay with Bandview for the minute. As I say, the new contractor would hopefully come in.
Well, if anything were to happen to Bandview, where do they go?
So then there would be a structured dispersal process.
The other
Where to, if the other practice is closed? We're you're bound to have a plan, because this is so far down the line, not fluid as you describe it. What is your plan B? Where do they go if Bandview isn't successful? What do you plan to do?
So I'll leave you to maybe talk about the detail of that process, Margaret.
If we're not able to secure a contractor, and as I say, the discussions that I'm having, and had those further this morning, I'm still hopeful. But our ultimate, Joanne, is in relation to dispersal. And as I articulated previously, it is a requirement on the board and the department to ensure each one of our patient citizens has access to general medical services.
And have you identified where they could be dispersed to?
Yes, we have a full mapping exercise already carried out.
And you've consulted with the GPs and other practices?
We've
that
had
they're willing
meetings
to?
with the practices, but as such we have not met with those practices to
Why not?
articulate the potential number of patients.
Okay, why have you not met with them?
Because we're still pursuing the issue of a new contractor.
Will you start it? I think no applicants received the 2nd December,
Yes,
so
well-
we are sort of, what timescale have you set yourself?
That is at the end of a formal process. Following the end of a formal process, we then seek and continue to seek a contractor. We are required under the contract to advertise within certain time frames, allow certain length of time for respondents, and we can't act outside of that until that process is finished.
Well, you have done
Yes,
that, but where do you go from here then? What happens then? You know, surely you haven't met with the other partners?
We've met on a regular basis with the neighbouring practices. They're fully aware.
You've consulted them every step of the way then, you're saying?
Yes, we've had several meetings.
And you've listened to their concerns?
We have, and the board has absolutely been in there in regards to supporting the current practice. We, as I say, Mark alluded to, we were able to identify advanced nurse practitioner as an independent prescriber. We have an independent pharmacist who we identified.
But I
and
think
made
that's
available
not
to the
kicking in,
practice.
I think Mark said, is that January? Or?
Well, no, there's twofold.
Already, yeah.
Obviously the crisis is now. I'm concerned over
Absolutely.
the Christmas
Yes.
period. What happens over the Christmas
Yes.
period?
Well, the
No one-
shifts in regards to, and we've been assisting the practice, working very closely, because as Mark alluded, these are independent contractors. Unfortunately, the current contractor was left on her own, single-handed.
I know that we've read the
Yeah,
very emotional
yes,
letter from her.
yes, yeah, which is not a position I would see any of my GPs in. So the board stepped in. We are not there to deliver the services, but we stepped in to assist our contractor. We assisted in finding locums. We worked with the practice manager to put her in contact with the locums. We've assisted with the finances. I contacted Dalriada to put in place the GP triage cover that we have there.
Well, will that continue all over the Christmas period?
Yes, it
Because, you know, as a local MLA, I certainly will be in contact all over the Christmas period because,
Yeah,
you know,
absolutely.
this is a major
Yeah,
crisis
yeah.
in Portadown, and it's reflective of what could
Absolutely.
happen across.
Yeah.
So you will be available, you will. I'm not hearing much about your plan B or what will happen.
Well, the ultimate plan B is a dispersal of the patients in relation to surrounding practices. That is our ultimate and last resort. It's not one that I take lightly. It's not one that I wish to put into action, but it is in the contract that each of our GP contractors sign up to.
But none
it
of
is a
the other
mechanism that we
practices
can.
in Portadown will be forced to take on them because they already can't cope, and it's 45,000 people.
Yeah, it's not a case, and I could under the contract assign, but the board, as always, we have always worked with our contractors, so although we may have to disperse the patients, they will go with additional resource and the support, whatever additional support we can give them, in addition to that the department have made available through the contract through federations. So, as I say, it is a case that we're working to find locum GPs to assist, but also building that bigger practice team. We've also been in contact with the local trust in regards to getting them to assist in regards to providing more nursing input, which they are working with
The
us
local
on.
trust is already under pressure because if
I
you can't get to your
appreciate
GP, then that's why we're experiencing what we're experiencing in Craigavon Hospital and other. I'm just not convinced. I'm in regular contact with the GPs, and I do feel we're in very, very, very dangerous territory here. That if
Yeah,
you've
I
nothing-
fully, honestly, Jo, I fully accept the demands that our GPs are under. As I say, I'm out there on the ground, I know, and we're experiencing those demands across the region. You know, I've been out more recently in Fermanagh, having to deal with similar situations. I'd say earlier in the year I was down Crossmaglen. So what we're trying to do, we do have a plan going forward, ultimate plan. It's great to see that the Minister has been positive in relation to the investment in primary
But we
care.
need something
But we
now.
need to,
We
yes,
can't
in
wait.
order down, absolutely.
You know, but we can, okay. Thanks, Chair.
Okay, I have another 3 more members waiting, so if we can motor on here as quickly as we can, Paula.
Just a quick one to start off with. In terms of the situation in Portadown, have you put in any increased capacity within the emergency department in the local hospitals? You know, because I know a lot of times if you can't get to your GP, you will has additional resources been put in?
So we've been speaking to the trust, but I
Yeah,
don't
the
think
trust,
there's...
It would be up to the trust to ascertain whether they needed to or not, but certainly from the 14th of October we made the trust aware of the difficulties with our contractor in Portadown. So ultimately it'd be up to them to then assess whether they need additional capacity put in to deal with it.
And they haven't come back?
So, and it's worth saying as well, all urgent appointments have been being dealt with by the Banview practice. So there shouldn't be, although the trust will be aware and standing ready, I wouldn't expect there to be any significant impact on the emergency department at this stage.
But I think over Christmas with the media attention on it too, I would be afraid that people will have assumed that they can't go there and they'll be going to the emergency department. But I'll just park that because my main question really goes back to a statement you made, Mark, around engagement with the BMA. You had said that you're working with them to see what can be done to address this challenge. I would like a wee bit more information on that because there seems to be a chasm between what you are saying and what they're saying on behalf of their members. I just want a wee bit more detail around what working with looks like.
So I think the main thing to point to is the GP-led care review, which the department led, but with the BMA and their representatives around the table, the RCGP, an independent GP, the Royal College of Nursing, a patient representing patients of GPs and others sat around that table saying, okay, what's the problem that we're facing? What are the drivers of that problem and what actions do we need to take? Do we need to address those? So, and as far as I know, both the BMA and the RCGP are broadly happy with the kind of the plan and the framework set out in the GP-led care review. It's just a case of taking forward additional actions from that review.
Okay.
But we would see, obviously, you know, the yearly contract negotiations with the BMA are underway at the minute, so I would spend quite a lot of time with Tom and Alan. We don't agree on everything. Clearly, there are differences between us, but certainly we would engage with them a lot, and the review process has given us an agreed framework of action between us all.
So why in the media then, as recently as last week, then we had the undated resignation letters? You know, as I say, that's really what the hub of it is, because that obviously, like Joanne said, a lot of this stuff is slightly more medium term, and so there's obviously the crisis there. So what is the body of your conversation with them now?
So the thing they're really looking for is the commitment from us and the confidence for them around funding, particularly over the longer term, and that's significant investment. The Minister did say, as part of our Health and Wellbeing 2026 document and speech to the Assembly, that she was going to invest in primary care. I guess the BMA are really waiting and looking to see the colour of our money, as it were, and see what kind of investment we can bring forward.
Okay, and very last question then. And when will that decision be taken? When will the BMA and others know of the colour of the money?
So it depends on the budget process. Obviously,
Okay,
we're hoping there will be a budget.
Okay. Thank you.
Thank you, and thank you for coming today. Like Joanne, I'm a constituency in Upper Ban, and myself and John O'Dowd were first made aware of this just at the beginning of the summer by the actual GPs who approached us. So I have two questions. My first one is, you're in talks with the GP, you're very positive about those, and just to commend all the efforts that have gone on behind the scenes up till now to try and if not eradicate the issue, sort of grasp a handle of it until we can solve it. So I do appreciate that. Is the GP aware of how urgent this situation is and the fact that this could result in a domino effect, pouring over into Lurgan realistically, where there's already pressure on our GPs? Do they understand the urgency of this and that we would need an answer sooner rather than later? And my second question is around the idea of putting a team of people in, maybe engage in the trust, and I find the Southern Trust extremely helpful in every aspect. And I think if we were able to put nurses, allied health professionals within the GP service in the meantime, that certainly would relieve pressure on the GP, because that letter that we received was startling.
Okay, so in terms of the contractor knowing how urgent it is, I mean, obviously that the person that they're in discussions with about potentially taking on this contract already has a surgery that they're running, so I guess there's some complexity in them coming up with their plans for their existing work, etc. But they understand the context, I think it's fair to say, Margaret?
Yeah. He absolutely does, and he is trying to put in place, obviously he doesn't want to commit to the contract unless he's assured that he can run it well. So he's trying to put in place the appropriate amount of GP cover, and he's been contacting individuals. He's absolutely aware, Catherine, of the timing of this. I say I met him last week. My staff were on the phone with him on Friday. We were following up with him again this morning. And we have, from the board perspective, we have said we'll fully support in regards to the cover. So it's not a case that he'll just, the contract itself is very viable, but in order that he can, get all of the sort of new patient, he gets to know the patients, he gets the GPs in place, he'll have additional support from ourselves. And you're very right in regards to the input of other allied health professionals, and we're trying to build that team at this point in time. But as I say, from the outset, we contacted the Trust, and they were very positive and very helpful in regards to, saying yes, we'll make available more nursing input in regards to assist the practice.
Thank you so much.
Just to follow on from that, because that's a good point. I mean, for the Trust to come in and provide some help short term can't happen long term, because we know what happens when the Trust come in, and if they need those people within their own trust, they'll pull them out again. So it's not a long-term fix in any way, shape or means to have Trust employees working within that GP scenario, but it is a way of a short-term fix that I think actually that the GP who's there, and hopefully the new GP, I mean, they can't possibly those two GPs can't possibly handle the workload, we know that. So if the Trust were willing to put in a short-term fix of that full multidisciplinary team in order to alleviate those pressures, that could go some way. So, that could be explored further and get back to us and let us know, because I think that certainly could prevent that domino effect from happening, albeit short term. There needs to be a long term measure put in place, but as a short term fix, it would certainly go some way of helping. Robbie, you wanted to?
Thank you. I'll be reasonably brief. Two things, just to follow on from what Catherine and the Chair just said. I'd be actually disappointed if you hadn't already considered that, given that some of the first indications, and this probably goes beyond this, back in 2015 in Crossmaglen, there was something building there. What my question previous to the statement made there was, given that this has been a long time in the making, what contingencies were you putting in place, and what was being put in place to, because obviously Bingo and the new strategy is going to be more prevention, and that's great, it's all to be very welcomed, but this has been a problem which has been building and has been recognised. The process for putting those steps in place to alleviate the pressures, not just on the GPs, when you read the letter, it's very heartfelt. The GPs want to serve the people and love but the patients are actually at risk, and also the GPs are at risk, and the doctor from Portadown wrote a very personal letter and bared her soul, and has to be commended for that. So on the back of what the Chair has said, were you looking at those things? And if not, what was your plan? Because it's...
Yeah, so I guess this is on two levels. Maybe the actions that we're taking kind of across Northern Ireland to roll out additional support, and then kind of the steps that we take or that we're ready to take once we know that a practice is in trouble.
Yes.
So I'll maybe let Margaret talk specifically about the kind of individual practices and the steps that we take. But obviously across Northern Ireland, we've recognised that pressure. We've increased the training numbers for GPs, but that obviously has a lag time. It takes 3 years to train a GP. We've started rolling out the practice-based pharmacists, and the first interviews took place over the summer for the first wave of those pharmacists. So this has obviously been some months, if not years, in the planning to get that large practice-based pharmacist scheme rolled out, and we have these other areas coming forward where we've put in place a retainer scheme to try and keep GPs working in the system. Margaret and the team have revised their returner scheme in terms of how easy it is for people to return to working as GPs, and we're starting to test some of that skills mix in terms of advanced nurse practitioners, physician associates, etc. So on a kind of Northern Ireland macro level, those are the steps we've been taking, saying when GPs are under pressure, what can we do to train more GPs, keep more GPs, recruit more GPs?
Sorry, Mark, could I just stop? I'm not being rude because our time's run out. We understand it. It's more what has been done. That's the prevention. That's the protection.
Yeah. Okay.
What I'm asking is, these have been identified. These GPs for a number of years have been on the radar as potential closures and that pressure. What is that? Not the build-up. What's going to be done to get in and save them?
So Margaret and her team have done a piece of work actually looking across Northern Ireland at which surgeries are most vulnerable in terms of the single-handed GPs, the two-handed GPs, in rural areas, etc. And have then been going out doing some work with them to say, well, how are you planning for the future as GPs? And having a group of people ready to step in and provide support where the worst does come to the worst.
Yeah, so we've been having a round of workshops. In particular, we've had the workshops obviously in Fermanagh area and the southern area as well, asking and working with our GP practices individually to think about succession planning, to think about potentials of, if one of their partners goes, or if one of their partners are sick, or indeed, like our current contractor, if they're left on their own, what their plans would be to address those. We've been working with them on that, so that's the sort of proactive bit. If, as indeed in our current contractor in Portadown and the one previously in Crossmaglen, the board does step in to assist financially, we can help with finding locums and finding other professionals to help out, so allied health professionals. But I can't dictate that they would work in that practice because they're in small businesses, so although we'll find them, it's still up to the contractor to say, yes, I'm happy to have that person working here. And we'll assist financially with that as well. So building the bigger groupings of the practice team, that's what I'm working with the federations on. And also asking them to look at setting aside some of that funding to have like a rescue team that can go around each of their practices to assist.
Okay. Robbie, you finished?
Yeah, that was just out of that. Just final point, and it's not a question. It's just that there's no legal grounds for compelling, because I think in a few discussions when I first joined the committee, there was there's an attraction to GPs going and working in the Belfast Trust, for instance, and working in and around the hospitals. We're losing skills. We're losing. There's this bit of a two-tier health system building up. I do fear when you look at where these prices are happening, but there's no legal precedent for compelling. So it has to be done.
I can't speak them out and put them no, unfortunately not. It's a good idea.
We need to look at anchors, I think, as well. Just one point I have. I don't know how these discussions ongoing with the perspective, or hopefully will ultimately be the contractor here. What does that entail? And I think Catherine had said, does he recognise, and does he have established the urgency with this to be done? Is it just negotiating terms at this stage?
Not negotiating terms at this stage, and obviously.
Is it a problem maybe that he recognises all too well? How urgently you need him on board?
Well, yes, I mean, he is a current contractor, but he is he is willing and absolutely up for a challenge. This will be a challenge. Will be a challenge. Nobody is doubting that. But he is looking at it and going into his eyes with his eyes wide open, and he knows that I and the board will be behind him in regards to trying to to take
Well,
this
well,
forward.
I think provision of care is paramount, but I'm just wondering in terms of the negotiations, are there potential stumbling blocks in the fact that potential contractor might well be aware of how desperately he's needed to come in here, and that will be impacting on his negotiating position? Let's just say.
Well, yes, I mean, I get the point you're making, but obviously any agreements we'll make will be based on a financial basis in regards to the support that we can back up.
Yes, it's got to be evidence-based in terms of the additional support we provide.
I just quickly, do you know if the Minister had said in a statement on the, had stated on 25th October that she was going to respond to the recommendations of the working group, the GP-led primary care services? Do you know if we're going to get that, the Minister's response to that, by the end of the year?
So there, I think it will be difficult to do so without the budget in any detail, but the Minister will obviously consider whether there's anything she can say without a budget in place.
Okay, we'll pick that up again then when we come back on our first meeting. Can you then, from what you've said today, thank you very much for attending, from what you've answered, or can we be assured then that over the Christmas period we are going to see a service within that practice that
Oh, yes,
will
There'll be
remain
a service
sustainable?
over Christmas, yes, and obviously we'll continue to work, and hopefully we'll have, news very soon.
Okay, look, thank you for attending today. Members, I just have a couple more things before we stop. I've cut out a whole load of stuff, so I will just probably move on to the date and time of next meeting, which is 10:30, Thursday the 12th of January in the Senate Chamber. Members.
Committee Room 30. This is the Northern Ireland Assembly Committee Room 30.